You're watching Formal Teaching and Problem Case Discussion, a primer, produced by GP Supervisors Australia and presented by Dr. Simon Morgan and Dr. Tony Saltis. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
So welcome all. We're talking about formal teaching, that element of the teaching role of the supervisor that's quarantined, structured, and really in many respects, the bit that a lot of supervisors wonder how to fill productively. What do I do? What do I teach? What methods can I use? How do I fill the time in a way that's going to meet the registrar's needs? And more specifically, as part of that, we're going to talk about problem case discussion, which arguably is the most commonly employed teaching method as part of those formal teaching sessions. And we're going to talk about a framework called PQRST, and there it is on the screen. And these are the learning objectives. And really, we are wishing to build on the content of previous webinars, particularly the webinar that we ran on planning learning and identification of learning needs. So that I'll revisit that very briefly, but really applying what you understand of your registrar's needs to practice-based teaching. But the big focus of this, strengths and utility and the range of practice-based teaching methods. And we're going to, as I said, focus on problem case discussion using this framework. And just right at the end, highlighting the importance of developing a teaching plan and how that really can help structure and formalize the way you do your teaching. We are very firmly based in Australian general practice training on the apprenticeship model, and it's worth reflecting on the fact that that isn't internationally consistent. Lots of places don't use that master apprentice model of GP training, where the supervisor sort of oversees the work of the registrar in the practice. But I think it's a great model and one I'll strongly support for a long time. And really the role of the GP supervisor, of which there's many, but probably the role of the teacher is the most apparent, that notion that the supervisor is a teacher, is an educator. And really when we think about teaching, certainly for the individual registrar, most of the learning, most of the education they get by a long way happens in the practice. They get some external tuition through the regional training organisations, but the majority of it is workplace-based learning and sort of formal and informal teaching that happens in the practice, of which you are responsible for delivering and overseeing. And so as opposed to informal teaching, we're talking about formal teaching, this regular quarantine structured teaching time, very much still as all the teaching opportunities and the supervision roles that you have an opportunity for assessment and feedback, but really how to fill productively that 1 hour or whatever it is of teaching time you have each week. And so just to differentiate them, and this is formal teaching versus informal teaching, where formal teaching is scheduled, informal teaching very much ad hoc, opportunistic, on the run. Obviously, formal teaching is a longer process because it is structured and quarantined. And really, the way we'd like to characterize it is that it's often more around registrar learning than immediate patient safety, which is, I have a problem, I have a patient in my room, I need some assistance now for informal teaching. So less urgent clinical care and learning needs versus more immediate. And case-based discussion, of which Tony will talk about in a little bit, is by far and away the usual method if you're doing corridor type ad hoc teaching, and very much problem-based discussion, as we'll be talking about for formal teaching, is a form of case discussion. But if there's one really important take-home message of this, it's to expand your repertoire. It's to use all the teaching methods that are available to you and really mix it up and make it engaging and interesting for both you and the registrar. So really just to revisit that first learning objective, the what to teach, and that's very much about learning needs. We're really focusing on the how to teach and at the end, the when and the where to teach. But just to revisit that notion of identification of learning needs, this is 3 minutes. If you want more than 3 minutes, I'd strongly encourage having a look at the relatively recent webinar we ran on planning learning. So really just to think that when you are identifying learning needs, they'll very commonly come to you with what they want to learn. And that'll be very much the things that they know that they don't know. So they'll be driven by clinical encounters, by exams, by the things they know they just need to get better at. But these 3 slides that I'm about to show you hopefully will encourage you to go beyond that, to think about the things that they really need to learn and they may have no knowledge of. The first one is very often they're seeking knowledge. And I think it's our role as supervisors. If we can do anything and do that well as supervisors or registrars in the practice, it's development of skills. So whenever you're doing your supervision with your registrars, knowledge is great and important, but many times they can get that from ETG or a textbook. It's skill-based. It's how you can apply those skills. The second slide, the second revisiting of learning needs, is the Johari window, which we talked about, and I've just alluded to, that registrars will be driven by the things they know they don't know. Your job to be an effective supervisor and to deliver effective learning is to help them uncover the things they don't know, the unknown unknowns. And the last one is just thinking about the breadth of general practice, thinking about the domains. And so very commonly registrars will be driven by domain 2. And again, I apologise, this is very RACGP centric. Registrars are driven by the clinical. What's the diagnosis? How do I manage that? What's the appropriate test? Which specialist do I refer to? Which is absolutely fine. And that's an important role clearly for you to facilitate. But thinking of communication, of population health, medical, legal, organisational, professional realms of practice, and how you can facilitate knowledge and skills in those areas. So that's my brief highlighting when we think about learning needs and the what to teach. But very much tonight is around the how to teach. And I would like to hand over to Tony.
Thanks for that excellent introduction, Simon. And what we're looking at now is the range of ways that you can use that hour, half an hour of dedicated teaching time. There is lots of choices of things that you can do in that time, not just casually discuss cases, although that does tend to be the default setting. Depending what you're trying to look at, what you're trying to teach, your method of teaching will vary. And it's worthwhile mixing it up for a couple of reasons. For your own satisfaction, because it's more effective to try different methods, and certainly more interesting for the registrar as well. So what we're going to do is have a think about all the different ways in which you could use different methods to fill that teaching time with your registrar. So here's a list of teaching methods we prepared earlier that could be used in, and it looks like an inordinately big list, but you can see that there's a large number of case-based discussions. There are topic tutorials, demonstration as a way of teaching, particularly procedures, and role modelling and role playing. An audit can be useful if you're organised, and certainly exam preparation and exam teaching can be useful depending where your registrar is in their training. So looking at that enormous list, you might look at those and think, well, yeah, that kind of makes sense. Most of what you're going to be doing will be somehow related to case stuff. And I would say that probably the next most common thing you'll use your time for is some kind of demonstration of some sort. Topic tutorials, which we'll talk about in a little bit, are not the bread and butter necessarily of that teaching time. They have their place, but maybe not as often as you might have thought. All right, so look, what I was going to do is just go through and really just pick out the essential highlights of each method, why they might be useful and what they're best used for. The main thing about this teaching time is just that you plan it ahead, that you intend to do it next week. You don't have to necessarily have a term-long schedule of every single thing you're going to do, but at least be planning for next week what you're going to do. Direct observation, a lot of you will obviously think of it as mainly done as assessing your registrar, and of course it's a fantastic way of seeing with your own eyes what the registrar is actually doing as opposed to what they did do in the past or what they would do in a hypothetical. You see them in action. Clearly, it's a fantastic opportunity to do real-time teaching. And I think the main strength is that you get to see exactly what's happened, and then you get to give feedback immediately as it's happened, or teaching immediately while the patient is still fresh in their mind. And in fact, sometimes even while the patient's in the room, but usually once the patient has left. I think in particular, it gives you an opportunity to do what you might think of as coaching. By that, I'm thinking of the act of giving an instruction watching it be performed and then giving immediate feedback, and then they do it again, and then they do it again, and then they do it again, like a tennis coach hitting balls at you all the time. The advantage of direct observation, particularly for communication and consulting skills, is that you can watch the registrar. Perhaps they looked at their computer too much in the consult, or perhaps they talked over the top of the patient. The patient leaves, you can give them that feedback and then watch them the very next patient and see whether they do it again. It gives them an opportunity to then refine what they've done, and you can go, yeah, look, that was a whole lot better. Try this again. I think that's one of the magic things about direct observation in terms of teaching. As I said, we know about it as an assessment tool, but it's a really good opportunity for teaching. Some of you might be teaching visitors. I've certainly done a lot of teaching visits, and although the assessment part of it is promoted, it really is a very valuable, and once the registrars are used to it and accepting of your presence in the room, they generally find it an incredibly valuable experience. So you can schedule, if you want, your teaching session, your hour, instead of doing some cases, say, look, book a couple of patients and I'll sit in with you and we'll see how you go. We'll give you some feedback as you go. It's just a matter of scheduling it to make it happen. It doesn't have to be just when the training provider tells you have to do it. It's worth doing the whole way through the term. Random case analysis is a brilliant way of teaching a whole range of different aspects of the case. Random case basically means discussing a case that is not brought to you by the registrar because they've got a problem with it. It's randomly chosen from maybe the last couple of days worth of patients. And the biggest strength, as you can imagine, of being random is that the registrar doesn't necessarily know whether they've done everything right or not. They haven't presented it to you because they probably thought it went fine. But you can uncover an amazing amount of hidden or blind or unknown unknowns by looking at what they've done and thought that they were doing fine. It's not about just picking the holes in everything that the registrar's done, but it's about revealing what has been done without the registrar's filter of presenting that to you. So that adds an awful lot of power to the teaching. You can then explore and interrogate the case like you would with any case. Why did you decide to do this? What other things did you think of? What investigations? Why did you choose that medication? So as a way of figuring out and then teaching clinical reasoning, it's a fantastic way of doing that. And the other really important aspect of random case analysis, which just increases its power, is the ability to add the what if questions. In other words, even the most banal, seemingly simple case, you can turn into something interesting by going, okay, you did that really well, but what would happen if this person was 40 instead of 20? Or what would happen if this person has chest pain lasted an hour instead of a minute? Or what would happen if you were after hours? Or you can add whatever you like. It can be quite playful, in fact, and you can turn even the most simple case into something that's really rich for discussion and teaching. There is a very, very well-written, clear GPSA guide on doing random case analysis, which I absolutely recommend. There's a few things you can do to value add to your case discussion. And one thing that you can do, it's kind of like random case analysis, but rather than analysing the whole case, you're really just focusing on the test ordering that was done during those cases. So it can still be randomly chosen, but you're looking at what tests were ordered. And of course, with a focus on why did they order those tests as a reflection of clinical reasoning and maybe even managing uncertainty. Is someone ordering a shotgun blast of tests for every little thing? Perhaps there's an issue of uncertainty, intolerance of uncertainty that you're dealing with. Rational test ordering as a skill and as an attitude and as an approach is very important teaching, and it's something that needs to be reiterated all the way through training. It's a good exercise to do, as I said, just choosing random cases and looking at the tests that were ordered. Or another way of doing it is literally just sit down and open their holding file of the results that have yet to be checked off and skim through and choose a few investigations and get the story behind them. And again, querying, what was this about? What was it going to tell you? How was it going to change your management? It can be a very, very useful teaching method. Within your case discussion, rather than actually deliberately spending all hour looking at referral letters, it can be really quite interesting focusing on referral letters. The referral letter has a few interesting features that are worth assessing, but also teaching about. To write a good referral letter, as you know, you need to be able to really succinctly represent the problem. You need to not blurt all the unnecessary stuff in the world. You need to frame the problem as succinctly as you possibly can. And you need to give the doctor you're referring to a really clear reason for why you're referring them. What's the question, or what's the problem that you've got? What's the reason for the referral? It's quite a skill, and it's worth looking and seeing how it's done and improving, giving feedback on how it can be improved. Obviously, it's also useful in terms of assessing someone's communication, particularly written communication skills, and how they communicate with a fellow doctor, with a colleague. It's a useful thing to do within random case as well. The last thing you can have a look at when you're looking at doing a random case is having a look at how prescribing went. What did they prescribe? Why did they choose it? You can focus on, was it safe? Was it a rational choice of prescribing? And it also can be an opportunity for you to review guidelines, particularly therapeutic guidelines, review or teach about PBS rules and so on. So that can be a nice little focus you can do on a couple of your cases when you're discussing them. Critical incident review, and I think they're a really important thing to pick up on. Obviously, they're an incredibly stressful thing to happen for everybody that's involved, but they are a magic opportunity for teaching, as long as you keep the process obviously very safe for the registrar, because the levels of stress can be quite high associated with it. The teaching is very much about, how did this happen? What were the steps that led to it? And of course, importantly, how can we prevent this from happening again? Clearly, the focus is on making sure from the practice and the patient's point of view that safety is maintained. But we learn from our mistakes. We don't like to actually face up to them. But as a supervisor, if you can provide a safe, blame-free, shame-free space for registrars to say, look, geez, I really didn't do this well. This didn't work out well, or maybe a near miss where things could have gone wrong but didn't quite. There's an awful lot to be learned from it. As a supervisor, to turn this into something valuable and to make it work, it can be incredibly helpful if you're prepared to share your own mea culpas. You don't have to give names and pack drills, but you might have a story of when you were back in the day when this happened and things didn't work out well and it was terrible and you felt horrible, that this is what we did about it and this is what I learned. You do learn from your mistakes, and it's fantastic if you can help the registrar to go through that process. Even better, if your practice is organised enough to have meetings where you discuss cases that went wrong. It normalises the process and it removes the individual from the process. It's just part of quality assurance, quality improvement to review those. So strongly recommend having a look at critical incident review. Most of you probably assumed, if you're new supervisors or about to be supervisors, probably think, God, my teaching time means I've got to stand up there and deliver a 26-week program of topics, complete with PowerPoint slides and videos and a lecture series. Look, nothing could be further from the truth. Topic tutorials have their place, but doing a session on atrial fibrillation or gout is probably a waste of your registrar's time, in the sense that they can read up about it. They can read the latest text or the latest guidelines or attend the latest course on the actual knowledge topic. Most of us as GPs are not really contact experts on any particular topic. What we are experts at is at being GPs, and we're very expert at the context rather than the content of what presents. So if we're going to do a topic tutorial, it's really important to try and relate it to cases. Now, whether they're real cases that you bring or the registrar brings, or made up cases, having cases as part of a topic session is incredibly valuable, because it allows you to show how you would process or how you would go through sorting this patient out. Some of you might have clinical expertise, some of you might be doing healthcare or sports medicine or drug and alcohol, and you may actually have some content expertise that doesn't come easily from textbooks, and by all means, please share that. But don't feel that if the registrar comes up to you and says, look, I want to learn all about the pill, point them to something, the family planning guidelines, or point them to a resource. But then instead of you delivering a lecture about the pill, you might deliver some cases about the pill and look at how that relates to the knowledge that they've learned. You are, as GPs, experts it's about some of the processes of general practice, which again are an important knowledge to know. We're content experts on maybe things like work cover or even care plans and billing and so on. That's not easily got out of books or resources, and running a session on care plans is a fantastic thing to do. References and guidelines can be useful to look up during the topic tutorial. And don't forget, this is an opportunity for you both to learn together. Registrars have got a lot to teach us as well. There are resources on the GPSA website. There's a whole suite of teaching plans which are very topic or presentation specific. And if you haven't already looked at those, they're terrific teaching aids when the registrar asks you, can you teach me about such and such, rather than going and looking up the topic. That can be one way of doing it. The last thing that you can do with a topic, if the registrar is really keen to ask you about it, is turn it around and say, well, how about next week you give me a 10-minute presentation and then we'll talk about how that applies to some cases. We're going to quickly talk about some other methods of teaching, demonstrations. So these are all kind of demonstration skills, and I'll just quickly whip through what they're useful for. Look, reverse direct observation is incredibly valuable, where the registrar sits and watches you in consultation. Clearly, most of you have or will probably do this at the beginning of a term, particularly with the term one registrar who's completely new to general practice. And it's a fantastic way of demonstrating obvious things like the way that you consult, the language that you use, how you manage your time, how you keep records, most importantly, how to navigate the computer, like prescribing and looking up results and that sort of stuff. It can be very valuable. It can be even more valuable if you deliberately target this as a session with some goals. In other words, look, I want you, while you're sitting there watching me, to listen to how I greet the patient, or listen to how I manage a list, or watch how I end the consultation. It's really important for them not just to sit there and be passive about it. Even better, if you want to be clever about it, get the registrar to sit and type the notes while you consult. That gives you some additional information on how they listen to the consult and what they pick up as being important, as well as their written expressive skills. I'd recommend it, particularly if you want to demonstrate later on in a term, maybe how you do motivational counselling or something along those lines. Get them to sit in with you for that consultation and demonstrate with a bit of discussion afterwards as well. And that can be a great way to spend half an hour or an hour of your teaching session. Physical examination. Look, obviously, we all know, and probably some of us are just as bad, musculoskeletal is probably the single most requested examination skill. Some of us might also be a bit rusty on examining the shoulder or the knee, but it's a good excuse to look at some fantastic videos, of which there are hundreds of good demonstrations, videos of joint examinations, and using the opportunity to practice on each other, or if you've got a patient in with you. That's a really essential thing to do, because they don't get much of that stuff in uni or in hospital time. And procedural skills. Well, it depends on what you like to do. If you're not a proceduralist GP, if taking your blood pressure is about as procedural as you get, then maybe this might not be something you're good at. But if you like taking things off or doing procedures, the best way to do it is to schedule a couple of removals or removal during the hour teaching session, or one of the registrars to schedule 1 or 2 patients, so that you can talk through the process. If you haven't ever read Susan Wern's very clear and sensible article in 10-year-old Australian Family Practice, it's a really great schema for how to deliberately teach a skill, which is a bit more subtle than see one, do one, teach one, but it does explain the stages of teaching a skill. Now, role play, and I think, again, most of you probably balk at the idea and think of medical school and having to role play some impossible character. It's a fantastic way of getting the registrar to rehearse even snippets of communication skill. Even a half a role play where you ask the registrar, for example, how would you ask this person a sexual history? Or how would you explain to a patient by role playing that you actually don't really know what's going on? Or how would you say no to a patient making unreasonable demands? Little snippets of scenarios where you just whip into being into character can be a fantastic way to actually practice, not say what you would do, but actually do it in front of you. Now, you could do half an hour of that in a teaching session, but it can easily be done ad hoc when you're doing a direct observation, or even in the middle of a case discussion where you decide, okay, let's have a go and see what you actually would have said to that patient. It can be a fantastic activity. There's no better way of learning something than having to teach it. Organising your registrar to look after the medical student or deliver a talk or a case to your practice is a fantastic way of getting them to actually learn a particular topic. And with your burgeoning teaching skills, now that you've attended all these webinars, you could even give them a couple of actual teaching tips on the way to make their teaching effective. Oh, and last of all, exam preparation. This would deserve a webinar on its own. We could spend an hour and a half talking about this. Essentially, you would have a role in either helping some role play cases or going through some actual written questions. GPSA teaching plans, which I mentioned before, all contain at least one kind of exam type question, which you could go through with your registrar. And certainly your training provider and the colleges provide a lot of guidance on how to help your registrar with exam preparation. But in that stage of training, we're ready for it. That can be a useful activity. Back to you, Simon.
Thanks very much, Tony. What a wonderful summary of what an extraordinary, rich cornucopia of teaching methods that we've got available. And thanks for picking the eyes out of those and really highlighting the strengths and utilities. As Tony, I think, really saliently said at the beginning, if we allow our registrar to drive things and we don't avail ourselves of the opportunity of the breadth of teaching methods, then commonly it will be problem case discussion, almost exclusively at times. But no matter what we do, commonly this will be what the registrar will be asking for and what will happen. So problem case discussion is by far and away the commonest teaching method. As we talked about, it's driven by registrar's learning needs. And I guess the nature and the urgency of the clinical situation. It's a form of case discussion, clearly, and as Tony alluded to, it has all those strengths of tapping into a registrar's clinical understanding, their tolerance of uncertainty, their clinical reasoning skills. Random case analysis does have that wonderful strength about being random and being able to pose what ifs, but there's no reason we can't do that with any form of case discussion, like problem case discussion. A couple of years ago now, I put together some thoughts and looked at the literature and came up with this model of problem case discussion called the PQRST. And it's really based on what my observation was around the way that supervisors commonly interacted with registrars around a problem case, often unstructured. So this is a hierarchy of ways a supervisor might approach a problem case. Here's the issue. So ask me the question and I'll tell you the answer. That's the simple tell. Now, many registrars will be quite happy with that. They get the answer, they get on with their day. But we've talked about the integration of teaching and assessment. We've talked about the scope of teaching methods to be able to interrogate and understand a registrar's reasoning and to see how they're going by way of that level of competence. So let's do something a bit more sophisticated, the ask before tell. Ask me the question, and then I'll ask you what might be the answer. I'll get a sense of what you've been thinking about before I'll help you. But even more sophisticated than that, ask me the question and then I'll explore it with you. I'll get a sense of what information you gathered, how you've synthesized that, how you've put it together, what your reasoning's been. And then I'll get you to give me a bit of a summary and then I'll help you with what I know. So I guess in a sense, if you apply that hierarchy and you go towards the bottom and your case-based discussion method is as limited as explore, ask, tell, you're probably doing a pretty good job. But what we would like to do is just to flag this method that I was lucky enough to get published in the AJGP this year, the so-called PQRST, which is an acronym you've heard before, but perhaps not in relation to supervision and case-based problem case discussion. And hopefully something easy to remember. What's the patient's problem? What's the registrar's question? How well does the registrar reason? What's the solution and what can be taught based on the very familiar letters from the ECG interpretation? So just to unpack those a little bit, what's the patient's problem? Now, it's pretty apparent that the first thing we're going to do is hear the registrar is going to present their issue and present the case. We would encourage you to ask registrars to present the problem in a so-called problem representation. And Tony's already talked about it. And I think actually when we think about referral letters, that is a very good example of how a registrar should structure a problem representation. Succinct, not over-inclusive. Patient demographics, the key aspects in terms of risk factors and background, the temporal pattern of the illness, is it acute, is it chronic, is it waxing and waning, and the clinical syndrome, what's occurring, what the presentation is, what are the associated features, but putting all that together in a really nice, neat package. And so already you can see by asking and in a sense almost reinforcing that your registrar presents cases in a problem representation format and almost pulling them up to say, how about try to put that into a more succinct problem representation? You'll get a sense of their reason. You'll get a sense of the way they're thinking, how they've synthesized and integrated information. What is the registrar's question? That's sort of so basic, isn't it? But I think sometimes we almost assume as supervisors, the registrar's asking me about this, they present the problem, and then you go off and you talk about what's going on without actually explicitly saying, what do you want to know from here? But not only what is your question, but in the background, and this doesn't have to be overt, it can be, but in the background, ask the question, why is this registrar asking me the question? What is driving them to come in and ask that question as part of this problem case discussion? Are they seeking rescue? As in, and that's much more, I think, the domain of an ad hoc encounter. I just don't know what's going on. I'm absolutely at sea. I'm sinking here. Just help me. Or assistance. Look, I've got a fair idea here what's going on, but it's not an area of strength of mine. So I'd like some help with this. Or reassurance. Here it is. This is what I think. What do you reckon? Well, you're actually doing a really good job and you're seeking my reassurance. And I think getting a sense of why registrars ask questions and then collating that over time, you'll get a sense of their level of competence and their confidence. Are they maybe competent but underconfident? They're seeking lots of reassurance versus they're really struggling. And perhaps as a GPT 2 or 3, you're thinking, why are they floundering so frequently when they're asking me questions maybe they should be a bit better at? So all that feeds into the R, which is the reasoning. And I make the point here that problem case discussion is commonly diagnostic. I don't know what's going on with this patient, or management. I think I'm pretty clear what's going on, or the specialist is advising, but really I don't know where to go with the management, or both. And so when we think of reasoning, it's not just diagnostic reasoning, but it's management reasoning. And so we've talked about the problem representation. I think exploding the differential, tell me what you think is going on and the breadth of possible options here. Tony's already alluded to uncertainty and the approach to the undifferentiated presentation. So getting a sense of how well and how tolerant they are of uncertainty. Their clarity, their efficiency in making decisions around management, and maybe how much they've engaged the patient in that, identification of the patient agenda, and incorporation of evidence. Have they looked stuff up? So this is a luxury. You've got an hour at the end of the day. You can really unpack a case rather than that 5 minutes of ad hoc supervision. You can really take your time and get a sense of your registrar's capabilities in these areas. S, obviously, a solution. Now, you may not have that, of course, and I think as new supervisors, it's incredibly important to say that we don't have all the answers. We very, very commonly don't have an answer. And that whole notion of looking stuff up together and exposing our vulnerabilities and saying, look, I'm a GP, I have some knowledge and I think I can assist you as to where to go, but that's not something I've come across either. Let's look it up together, emphasising the ask before tell. And I guess what can be taught, and Tony's already, I think, really nicely talked about that as GPs. We do have the context. We may not have the content knowledge, we may, but it's very much what would we do? How would we approach the situation as a GP? But the registrar will also be seeking, well, what are the diagnostic criteria for this condition? Or, what is the best management? Let's look up the appropriate evidence together. So that is PQRST. And I guess in saying that, it's just a framework really to be able to apply. And I think like any framework, if it works for you, great. If half of it works for you, great. If it doesn't work for you, it's fine. But it just gives you a bit of a sense of some of the areas I think that's worth covering. Now, we're going to just very quickly just give you a bit of a demonstration of how this might look. And I think I'll make a point here that, so Dan's a first-term GP registrar, GPT-1, his supervisor is Adam. Important to set this up. It's the end of the day, but it's quarantine teaching. Patients are finished, there's no pressure. Yeah, we've got some time now. And clearly, as we said right at the outset, fundamentally, this only works when there's a relationship. So Tony and I are now going to role play Dan and Adam, but we've had a time together, we know each other, we've got a sense of connection about how things are going to flow. So it may look a bit artificial, but that's the backstory. G'day, Adam.
Oh, okay, Dan. Look, you wanted to do some cases today, I gather. So look, what have you got for me?
That'd be good. Yeah, look, I've got a few actually, but I wouldn't mind asking about this woman. She came in, she's got this really bad shoulder, just really sore, and it's funny, she's
okay, yeah. Do you remember we talked before about just try and have a go at presenting this as if you were putting it into a referral letter?
Yeah,
Just
yeah.
concisely, remember,
Sorry,
problem
yeah, yeah.
representation. Just see how you go presenting it that way for
Yeah,
starters.
no. Yeah, yeah, thanks. You pulled me up on that before, and it's good practice, actually. So, all right. So she's 47-year-old woman, school teacher, and she presents with 3-week history of right shoulder pain. It's come on spontaneously, no history of trauma, really problematic when she's reaching up above her head, doing up a bra, and it's sort of located on the outside of her shoulder. So it's just getting worse and worse. And I sort of was talking to her about going to the physio, and she's actually not that keen. And she's really seemed a bit resistant. I'm just not sure where to go. Yeah.
Okay. Look, all right, that was a better summary. Remember that just to try and give a bit of an idea of how time passes in the history and maybe some past history as well. But anyway, so look, that's good. So what do you want to know about this? What's your question?
I mean, I guess I'm not entirely sure what's going on, although I'm pretty confident she's got a rotator cuff, a kind of bursitis thing.
Right.
But I guess she actually wanted to know whether she could have an injection. She said she had a friend who had the same thing and went off and got a corticosteroid injection and fixed it. And I just really not sure whether that's the way to go with it. I've not really seen this in general practice at all, really. So, yeah.
Okay, so your main concern is whether this is something that should have an injection. But look, I guess you sound not 100% sure about the diagnosis. What else did you think about? You said you think it might be some sort of rotator cuff thing, but what else did you think about when you came up with that?
Well, look, it was pretty typical. Like I was thinking about whether I'm not entirely sure whether I should get an ultrasound to confirm it, but I'm not sure how much value that adds. I read something about it that we're doing too many of them. I tried to ask a bit about the nasties. There's been no trauma. She's really well, so there's no history of cancer or anything. And I did ask about sweats and fevers and stuff.
Okay.
So
good. So, I mean, you tried to exclude the things you shouldn't miss.
Yeah.
Most likely thing, what would you say that is then?
I reckon it's subacromial bursitis or a supraspinatus tear or something like that.
Okay. All right. Any other red flag or any other history that you might have thought of? You mentioned possible malignancy. You mentioned infection. Any other nasty?
No. What else should
okay. Oh, I mean, maybe fall or trauma of some sort. Like that.
Oh, yeah. No, yeah. She hadn't had a fall, she said, which was, yeah. So, yeah. So it's just this thing of, I was pretty confident that's what's going on. And I said, how about some physio? And she was kind of angling for this injection. And I just thought, well, I don't even know whether it's any value,
Okay. Well, what do you think? I've got my thoughts about it, but what do you think is the idea? Do you think that's a good idea?
Well, I guess, I was going to try to look something up on it and I haven't had a chance. I always find this a bit hard because the patient, she's a bit sort of, she dismissed me a bit when I suggested that physio would be useful. But I can imagine it's going to be a bit invasive and I'm sure there's risks. Sure. And what's your experience? Are they good?
Look, I agree with you. I think the way you described the case, it's most likely going to be something to do with the rotator cuff. And you asked about ultrasound. Look, I think it has its role, but maybe it doesn't need to come into play straight away. There is some evidence for and against it. And certainly in terms of injection, look, they also do have their role. They can certainly improve function and pain for certainly some period of time. But generally speaking, you wouldn't go down that track first line. And I think your idea of starting with physiotherapy is the sound one in this situation. I think you would leave decision about an injection until she's had at least a couple of weeks, if not more, of physio and see how she's going. I think would be a reasonable approach.
Thanks, Adam. That's really helpful. Do you have a go-to resource for this sort of thing?
To be honest, I don't. I think we probably both need to look this up together. I know that I recently read some article about the utility of shoulder injections and in particular whether you should use ultrasound to guide them or not.
Okay.
But we might need to look that up together. In fact, you'll probably find it quicker than I will.
I'll have a look.
And I think the other thing we might do at some stage is we might go over shoulder examinations again. Just sort of hone your skills on that. I'd be happy to teach you that. I think I've got a good handle on that.
Oh, that would be very helpful. Thank you. Great. So no prizes there for any acting, but just a bit of a demonstration. And hopefully, as you were watching that, you could sort of see the P, and Tony was, hopefully reasonably deliberate about what's your question. And then maybe getting a sense of why am I asking the question? Does this fit with Dan, the GPT-1? Is he going pretty well? What's his level of confidence? Is he seeking reassurance or he's drowning? A nice exploration of reasoning. bit of a sense of differentials and red flags and what's going on and the role of investigations. And so solution, I think it was pretty clear. I got some good advice there as the registrar and some teaching towards the end. So it's organic and it's going to happen kind of anyway, but if you just think of it in that structure, it may be beneficial. So the PQRST, as I wrote in my paper and towards the end in terms of why this might be useful for supervisors, is that it's nice and simple, it's easy to remember. It can actually also be used for ad hoc teaching. There are existing models like the 1-minute preceptor, but PQRST can be applied in that opportunistic corridor type model as well. And it's got a focus on the registrar's question, which sometimes, believe it or not, gets lost. It's got this very explicit focus on clinical reasoning, interrogating the registrar's thinking. It prioritises patient registrar safety, and it's available and accessible and has utility for registrars of all levels of training and competence. So we have spent the vast majority of this webinar talking about teaching methods and hopefully just really reinforcing what's most common, problem case discussion using the PQRST model. And we really can't finish without just 30 seconds, literally, on the when and the where of teaching, the practicalities. And it's just so important. I think Tony mentioned it already, but we have to make sure that we plan this teaching, this formal teaching, appropriately. If you have access, and this is from GP Synergy, but if you have access to a regional training organisation teaching plan of some sort, then you might actually be mandated to use it. You might use it optionally. If you don't, make it up. But basically, when and how will formal structured teaching occur during the term? We know there are some pretty clear rules around this, that if you attempt to do it at the end of a busy morning, at lunchtime, often patients get in the way and it doesn't occur. So we actually set that up at the end of a day, but ideally I think it's at the beginning of a session when there's less likely to be an intrusion. It needs to be quarantined. It's such that the time's booked off and no interruption. So take it really seriously. This is really important time that can't kind of just happen in between patients. And I think Tony also made a really nice point. You don't need to have 26 weeks mapped out. Now, I know some supervisors do that and they love it and the registrars probably really respond to it. But if it's literally, let's think about what we're doing next Wednesday, how about we do a couple of cases if you've got something that you need to discuss, and we'll do some RCA. I might even do a couple of practice examination, musculoskeletal examinations. So you just know what's following on. So that level, which isn't hugely onerous, write down, document, this is when we're going to do the teaching and how it's going to look, and maybe even the breadth of methods we might try to employ over the course of the term. And at least a week ahead, make some commitment as to what you're going to discuss and how it's going to be done. So in summary, we touched on the what to teach, the learning needs, and remembering that the registrar will have a whole range of learning needs beneath the surface, those that they need to help to be uncovered, and clearly those which we need to support. Think beyond the knowledge, think of the skills, think beyond the clinical, think of all the breadth of those domains. So applying those needs into your practice-based teaching, I think Tony's given a really eloquent and comprehensive discussion of that wonderful breadth of methods. He's talked about playful and fun. This can be so rewarding to just do something different and have some fun. And in a sense, almost don't take it too seriously. Like, I'm not the expert here. I'm a GP and I've got some good ideas and I've been doing it for longer than you. You're talking to the registrar now. But let's work through this together. Let's muddle through this together and walk stuff up as we need. We talked about problem case discussion using PQRST, and just that really important point touched on quickly, developing a teaching plan. Thank you very much, Tony.
Pleasure, Matt.
Wonderful to present with you. Thank you very much for your wisdom, which I think is the combination of 20 years of doing this stuff. So really nice to hear those summaries around all those teaching methods, and we'll see you soon.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervisors Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.